Now, you're asking ICD-10 stuff, right? Okay, obviously, you're in the 102 class. We're still in the 101. So, good question. I will answer all that, but you'll have to come back at 1:30 for that one, okay? Okay? And just sit here, wait while we go to lunch, and then when we come back, I'll answer it for you. Okay, we'll get to that. And that's not an easy answer. It sounds like easy, but it's not, okay? I'll explain it to you. I really will, okay? All right. Okay, so where were we? Okay, codes that describe symptoms and signs are only acceptable if that's the highest level of diagnostic certainty. Think about it. Lumbalgia, back pain. Isn't that a symptom? Yes. Muscle spasms. Isn't that a symptom? Yes. And so therefore, those are only acceptable if that is the highest level of diagnostic certainty. No other diagnosis has been established or confirmed by the provider, then you can use those, but it's not the usual. We examine our patients, we x-ray our patients. Signs and number 3 there. Signs and symptoms that are associated routinely with a disease process, i.e. spasms, and maybe in some insurances, even subluxation, should not be assigned as additional codes unless otherwise instructed by the classification. I am subluxation based, okay? I adjust the subluxation. But Medicare requires subluxation code number 1. Many other insurances don't. Blue Cross told me, actually told my wife, she was talking to them, she's a certified professional coder, and they said, if you put subluxation code number 1 on Blue Cross, now this is Blue Cross of Illinois, it's worth about 3 visits. And he said even a sprain is worth about 8 visits. Now that was Blue Cross of Illinois. The key is that you don't always have to use, it's not a philosophy thing. It's a monopoly thing. Monopoly, you know the rules, the bank pays you. Okay? But the key is, it's not a subluxation code. And I don't care if you use that or not. But lumbalgia, cervicalgia, lumbalgia is the number 1 diagnosis that Medicare says that patients, doctors, chiropractors use for Medicare patients. But if you think about it, what's the number 1 condition that we see in a Medicare patient for their lower back? Degenerative disc disease, right? Right? But you got to have an X-ray or MRI or CT to show that, okay? All right. So, again, the problem is that we, if you call it a problem, is a lot of times, we are just used to doing that all the time. And just like on Thursday, it was for a Blue Cross patient, the doctor had a 98941. Number 1, the patient was complaining of back pain and only back pain. He had a 41. When we asked him how much he charged for 40, his staff told us 98940 was not even in the computer. So everyone walking in the door gets a 41, and his diagnosis was subluxation of 4 regions. And that's it, no medical diagnosis. Okay? So again, what codes are you using, and is this really supported by the information you are given? Be more specific. Now, you're thinking now, I'm thinking ICD-10. In ICD-10, it will be required to have higher specificity of codes. And unspecified codes many times will be denied, okay? There are, here's ICD-10, an example, R45.2. Some of you may be already experiencing an R45.2 unhappiness, okay? All right? But that is a state of mind, but not necessarily a condition that an adjustment, well, it might help out, okay? All right? So codes, signs, and symptoms when a related definitive diagnosis has not been established, confirmed by the provider, that is okay. In other words, you can use a sign or symptom, but hopefully you're going to get off of those pretty quickly. And what I was thinking the doctor was starting to say is that first visit, if all we know is a lumbalgia, that's okay. But not by the 6th visit. Here, give me something beefier, more meaty, if you will. Okay? So, again, here's some examples. R68.84, actual ICD-10 codes. No, it's not in your notes. It's okay. You can write. I think the pens are right next to the cookies. Okay, you'll find it. So write down, these are codes here, but you can look in the book as well. You don't have to memorize codes. But the key is, what you need to get out of this, jaw pain would not be coded along with temporal mandibular joint arthralgia, and definitely not along with some DJD of that. So as we go up the hierarchy of the specificity of codes, you always want to use the more specific code. All right? Like R11.0, nausea. Okay? Is that the code you want to use when the patient has a migraine headache? No. Why? Because you diagnose, if they have a migraine headache, you're going to diagnose the migraine headache. So in other words, you went through, you did a virtual tour of your office, you got your playlist of your codes. Now you look at that playlist and you go, you know what? It's a good time to upgrade this playlist. Okay? Tube socks are gone. All right? And so these groups are gone, so maybe now it's time to get out of the 80s. And so now you move up on your playlist of songs maybe to the 90s. Ooh, okay, right? Get some Neo or something, okay? All right, okay. All right. Some of you are still listening to those 80s songs. I understand that, which they're good songs. But the key is upgrade your diagnosis list. Some people look at me, but I'm used to that. My wife looks at me like, where are you coming from? Okay, anyway. So sprain of ligaments of the cervical spine, S13.4 XXA. Okay? Isn't that a better one than cervicalgia? Sure. Okay? And everyone's worried about this A, D, and S at the end there. I will teach you that. It's like one of the least important things that we're going to talk about all of today, to be honest with you. It is literally the least important thing we're going to talk about. The first thing you want to do is look to see, how can I be a better diagnoser? You didn't go to school in all the years of practice to tell me that the patient has neck pain. And I'm talking doctor to doctor. What does the patient really have? Okay? Coding for diagnoses that are probable, suspected, or questionable are not to be coded, and that's how it is now. This is a big deal. You examine the patient, and so you examine the patient, you feel that that patient has a herniated disc. Can you put it on the claim form? The answer is no, unless you have an MRI or CT scan to show that it has a herniated disc. Now let me give you a clinical example, a little anecdote, but nonetheless it'll work, okay? Patient comes in, they have severe pain. I just had one come in a couple weeks ago. He was sitting at Bob Evans having breakfast. He got out of the booth. He felt a sudden onset of pain. He didn't do anything out of the ordinary. This actually happened. He was in severe pain. He walked into my clinic. We were busy. We got him right back. I walked in, and he's leaning against the counter, and he is in severe misery. He has antalgia. He had pain shooting down the leg. I thought he had a herniated disc. Okay, so I examined him, we worked on him. He came in the next day, and when I walked in the room the next day, I didn't make him wait because he's in bad pain, right? He walked in there, he goes, "Doc, you are a miracle worker." And he's standing straight, and he had no leg pain. Now, that's the power of chiropractic, okay, but the key is, I thought he had a herniated disc. I didn't cure the herniated disc that quick. He had antalgia because of the edema. So therefore, I suspected he had a herniated disc, but now if I put it on the claim form, it's there forever. It's in the national database that he had a herniated disc. So in your notes, you're going to put down suspected. What did he have? Well, he had leg pain. He did have a positive SLR, so at least it's sciatica. It could be a lumbar sprain. But lumbalgia is not the best diagnosis because he had more than that. He had signs and symptoms and exam findings, objective exam findings, that said that at least he had sciatica. Do you understand what I'm saying here? Okay? So lumbalgia, it's easy because that's what we use all the time. And maybe you don't, but many doctors do. And so therefore you have to help it out here. So just because they have what you suspect is a herniated disc. I was teaching for the American College of Chiropractic Orthopedics. It was a tough gig. It was in Hawaii, okay? And they argue with me, I am a DABCO, and I examine my patient. That's right, but you don't have proof of it. You suspected, yes, put it in your notes, but not on the claim form. I'm telling you this so that you hear me properly. When you suspected, you talk to the patient. I will tell the patient, I think you have a herniated disc. If you're not doing better by Friday, then I'm going to send you for an MRI. In the meantime, I want you to take these precautions. I'm going to put you on these restrictions. The patient knows in their brain, because if they go to their medical doctor and they'll say, you know what, the pain is so severe I can't stand it anymore, I need medication. I saw Dr. Fucineri, he suspects I have a disc herniation. Now, if the doctor does an MRI, the MD does an MRI, and the patient finds out he has a herniated disc, he'll call me up or come into the office and say, you were right. If I don't tell him that and tell him to take precautions, he'll say, the MD found out what's wrong with me, I have a herniated disc. Now, nowadays, the MDs don't run to an MRI that quickly as they used to. Medicare, you have to go through protocols in order to get that MRI, and that's why MRI is not ordered. But the key is, talk to your patient in such a way for risk management and tell them, what are the red flags? Well, obviously, if they have bowel or bladder changes, not where they are incontinent, because sometimes they just can't go. But the key is that goes in your notes, but not on the claim form. So always ask yourself, and I'm drumming this home all morning here, always ask yourself, what is the most specific diagnosis I can give this patient now? Okay? Everyone with me? If you don't remember this, you're probably going to be denied. And I will tell you that, I can't mention anyone that I've talked to because it's a lot of times off the record, and it's nothing to do with H&S here, but I have had 2 insurance companies say that they are going to audit all unspecified codes. Just because they know that there's a way they can recoup some of their money. But you're going to be better doctors than that. And I mean that. And just, pat yourself on the back, give yourself a high five because nobody else will, right? And just say, you know what, I'm better than that, and so I'm going to diagnose properly. And this is the time to, hit the reboot button, if you will. Okay? All right. Yes? Yes? Well, if there was no leg pain, he was in activity. He was in activity when he hurt himself. So if anything, it's a lumbar sprain. Well, there was. He was getting out of a booth. He was sliding over. No, he was sliding out of a booth, okay, and his back went out. He had a sudden onset of pain. Well, okay, so in the hierarchy, you have symptoms like muscle spasm. Okay, then you have lumbalgia, and then you have a sprain, as an example, maybe facet syndrome, right? And then you have hernia or sciatica, then herniated disc. Out of that hierarchy of the list, which one is most appropriate? Okay? So I look at it that he was doing something at the time, so he had a lumbar sprain. Okay? Now, you know what? When it comes down to it, Doc, it doesn't matter because the insurance company is going to say, oh, this doesn't count. No, it's a lumbar sprain, which is better than lumbalgia and definitely better than muscle spasm. All right? Now, if he did not improve, all right, or if his signs and symptoms, as you said, what if he didn't have, you asked if he didn't have leg pain, sprain. He did have leg pain, positive SLR, so now it moved up the ladder of hierarchy, and so now I'm going to give him sciatica, okay? If he had some red flags, caught equina, or he did not respond to care, now if I have to, and you know most of them don't need an MRI, okay? But if I had to eventually get an MRI, then if that confirmed that, like one of my patients had an extruded disc, now we will give them a 722.10, okay? So the key is, at this point here, I want to transform your thinking a little bit more, okay? Yes, ma'am. Okay, say it one more time. Yes. What do you mean by kicks our claims out? Okay, why? Why? Well, you got to call them. Well, okay, so that's their criteria. Because Blue Cross in my state, which is a different Blue Cross, they don't kick those out. They don't say that. Okay, so I don't know all the ramifications here, and talk to H&S as well, and maybe their policy can be changed, because obviously that's wrong. I mean, it is, okay? But you got to call them up and find out why is this, and argue. Squeaky wheel gets the grease. Yes, ma'am. So she said, in those cases there, it's an accident, but it's not a car accident. So box 10, it asks, is this a work comp, is it PI, and is it other? And she's marking yes, and then it goes through, okay? See? All right, so take her out for lunch. Okay, give her a free lunch, okay? Oh, wait, it is provided. Okay, see? All right, see? All right, okay. All right. Coding for diagnosis that are probable, suspected, rule out, etc., are not allowed for outpatients. The term first listed. Now, here's a good one. Okay, this is, you see, and I like this. I want to evoke thought, because then you'll be a better diagnoser and a better documenter, right? And everyone will like that. The term first listed diagnosis is now to be used instead of the term principal diagnosis. Who cares? What does that mean? Well, number one is always, whatever is in Italian, pretty, which is acute, okay, that goes first. You're just looking at me now, okay? See, you're just getting too serious. Hey, that's acute, okay? Now it's acute, okay? So anything that is acute goes first. Okay, here's an example. Patient has degenerative disc disease, and they have, let's say, sciatica. Which one will go first? Sciatica. Okay, why? Well, number one, you always put a nerve problem first. So neurologic goes first. This is in your notes later on, by the way, okay? So neurologic goes first, and whatever is worse goes first. So therefore, train your staff that the order that you put the codes in, doctor, you code the patient, keep it in that order. Because if they have a thoracic sprain and a lumbar sprain, okay, now which one do you put first? Well, which one is worse? Well, their lumbar is worse than the thoracic. Well, then lumbar goes first. All right? Yes, sir. Right.
Now I understand that 728.85 muscle spasm is a drug you can't diagnose. Obviously, as the primary, you wouldn't want to use that. However, if you didn't objectively have that, is there anything wrong with it putting that somewhere secondarily into the
Yes. Okay, he's saying he doesn't have muscle spasms, but can you put it later on in the list, is what I'm saying, on the claim form. The answer is no, you don't want to do that because it's redundant. It's a symptom of the problem. In other words, when a patient has a sprain injury to the lumbar spine, would you expect edema? Would you expect pain? Would you expect spasms? Yes, because they are symptomatology that goes along with that, and so therefore it's considered to be redundant. Okay? No, I'm not saying denial. I'm just saying a better code. Okay? What I'm explaining to you it's not Mario's guidelines. These are the official guidelines, and many of them, you already are working under them with ICD-9. It's just, they're worthless. Okay, as you said, garbage can diagnosis. Why is it garbage can? Because a muscle spasm is part of the sprain or part of sciatica. You can do a leg pain.
I wonder why they're in there in the first place if you should never use them.
No, what you're asking is, why does the World Health Organization have all these classifications? Because if that's all you know, then you would diagnose it. But you're telling me that you know more, and so therefore you're going to go up the ladder. That's the whole thing, okay? If you start saying, why do they have that there in the first place? There's many different codes in ICD-10 that are there that you will never use because they're unspecified. The whole thing is, I keep telling you, do not use unspecified codes or a lesser hierarchy of codes if you know more. And that's the key. That is going to save you, and I'm not talking about H&S or anybody else here. I am talking about, in general, with insurance companies, that will save you so many hassles with denials.
It seems like, well, why did we expand the number of diagnoses available to 10 when we should just have this one great one?
Why don't we just send in, a token and money comes out of the machine? I mean, that's the system. Okay, remember, only in the United States have we taken these global data codes and now converted them over to mean reimbursement. In Europe, they don't get reimbursed based on the codes. This is the system we have adopted for, at least since 1993 with ICD-10. Yes, all the way in the back. It doesn't matter. Okay. I mean, he's talking about Colossus, but that doesn't matter. Okay. Okay, one more. Go ahead. I understand. But what all of you are missing, the point here, is that ICD-10 was the reset button. And everyone on earth is resetting the way that we code. And these guidelines that I am reading to you, you're talking to me about the way it is now or the way it was, and I'm talking to you the way it will be. In all insurances that I have taken many webinars even with insurance companies, okay, and they all indicate there's going to be a change in the way we look at codes. And I'm teaching you that change, okay? So, it's kind of like, okay, we're all going to French, okay, but this is the grammar, the rules you have to use. These are the rules we're going to use for those codes, okay? Okay. Okay. Again, you're talking to me about now, I'm talking to you about the future, okay? So now, in more specific ICD-10, you're going to have to give the condition, not just, that they have spasms due to a lack of potassium. Okay, each unique ICD-10 diagnostic code may be reported only once. However, if you're using a left and right code, you only list the diagnosis with the sides once, but there's certain ones, and you might want to put this into your notes, that when it comes to arthritis, osteoarthritis is one of those in our scope of practice where they have multiple site codes. Osteoarthritis are one of those conditions where they have multiple site codes. Because, a patient will say, my knee is killing me today. Tomorrow, it might be their ankle or their elbow. And so it's multiple sites there. But if there is no multiple site code, you will have to list left and right or multiple sites. And that's why we have 12 lines in box 21, Okay, all right. So if the condition is bilateral, then there's no bilateral code. You have to list each one separately. And if it's borderline, then it's listed as confirmed. Borderline diabetic, borderline hypertension are gone under ICD-10. Okay? Those terms are gone, no more borderline. Either you have it or you don't. Okay? That's how it is under, and again, okay, it comes to the change. You'll say, well, we used to always do it this way. Yeah, you used to do it. Now we're going to have to do it this way. And that all kicks in October 1st, 2015. Okay? All right. Okay. All right. Unspecified code should be reported only once when it's a code that most accurately reflects what is known about the patient's condition. It's inappropriate to select a specific code that's not supported by the health record. Again, here's an example. Notes that I was looking at just recently for the doctor. Every cervical case, literally, and I would say every cervical case, he did brachial neuritis. That was what he did. I had another doctor from Kentucky. She said, every lower back case that I have that comes in, I diagnose them with sciatica. I said, why do you do that? She said, somebody told me that they'll always pay for sciatica. Anytime you're doing this because then I'll get paid, or anytime you're doing this because I get paid better, that is considered to be fraud. All right? In this case, the brachial neuritis, the doctor had nothing, he did examine the patient, had nothing that showed it was a nerve problem. I mean, even, not even facet inflammation. There was nothing a problem. But anybody walked in the door with cervical problems, he said brachial neuritis. Okay? So the key is, again, you have to look at your diagnosis, the codes you're using, and I'm sure if I went through all 300 of you here, I would find at least some of you that the staff would say, oh yeah, he uses these codes all the time. Okay, so now I want you to just question, how are you going to be looking at that? Okay? All right. Okay, any other questions first? Okay, now I'm already feeling, I'm stretching your comfort zone a little bit. Now we're going to get into it here, okay? And when we come back from lunch, we're going to get into it very specifically, but I want to just start off and end the morning off with a couple of definitions that will affect. And that doctor that was asking about the AD and S, you're going to get an appetizer for your lunch because I'll answer your questions for that, okay? See? So now you'll be able to enjoy your lunch a little better, okay? All right, first of all, what kind of practice do you have? Do you do nutritional stuff? Do you do orthopedic? I feel my practice is more orthopedically based, which means, nutrition, I talk to them a little bit about nutrition, but, it's like I don't hit it that much as opposed to some offices, all right? And so when we look at ICD-10, why do we need 70,000 codes? You and I do not need 70,000 codes. We don't even need 17,000 codes under any system. But acute versus chronic, there's actually 1,764 different codes that are just for acute and chronic. So that doctor there who wants the AD and S meal, the buffet, there's 1,764 codes you can choose from. Go for it, okay? You can eat a different meal each day. Fractures, open or closed fractures, over 10,000 of those codes there. Routine heal, delayed heal. Look at the fractures. Think what the orthopedic doctors for fractures. They're going through this, right? But now, you and I, as well as orthopedic, right versus left, over 25,000 codes. And yes, you will be responsible for a lot of those codes, okay? Initial encounter, subsequent encounter, or sequela. Doc in the blue shirt there, what is your first name? Leonard, okay? These are Leonard codes, okay? That's what he was asking about, the AD or S, okay? So just call them, hey, that's Lenny codes, okay? Okay? 47,000 codes just for AD and S, all right? And so how are we going to address AD and S codes there? I will teach you that, and I'll teach you what I know, what I think, and the way I will see, okay? All right, so first of all, There's a whole lots of codes, okay? There's chapters here, 21 different chapters. Now, look over here. Just look up at the board here. And so if there's somebody, how many of you deal with nutritional counseling in your office where you do a lot of nutritional stuff? Raise your hand. Okay, now nobody wants to raise their hand. There was some over there. Okay, now, I am not going to teach today from chapter 4, but those of you that just raised your hand, go to chapter 4 of the big book there. You're going to have to study those codes. It's a 4-hour class. If they had me come in for 12 hours, okay, then we'd all be having a bar at the back there. But number one. Number two, we'd then go through chapter 4. Chapter 6, those are diseases of the nervous system. Those you would think we're going to use those as chiropractors quite a bit. Actually, not that many. Okay? But when we look at chapter 13, diseases of musculoskeletal system and connective tissue, we're going to be using those a lot, and I will teach you those this afternoon. Okay? Chapter 15, I didn't highlight it, but I'm going to go over that. And for our scope of practice and things we're treating here, since we're not treating, placenta previa and stuff like that, I'm going to teach you the code. It's so easy. Come back at 1:30. Don't be late, okay? And you'll learn those codes really easy, and it's kind of like you'll do it just out of your head, okay? No problem. Chapter 19, you're going to be using those a lot. These are all your sprain, strain injuries. They're huge, okay? They're a lot. And unfortunately, those are the Lenny codes too, A, D, and S. See? Okay, hope you don't mind me calling you Lenny, okay? All right? So he goes, oh no, as long as I'm popular, put me in my book and make sure I get a royalty. Okay, so chapter 20, those codes, I've had questions. I used to, on my bigger class, I used to do case scenarios. And chapter 20, here's a case scenario. Patient jumps off of a high dive into a bucket and hurts his neck. So using chapter 20, diagnose those codes there, and those are the injury or activity codes. Well, high dive versus low dive are two sets of codes, seriously. Then, hurt his neck hitting a bucket. There's one code, as an example, hurt his neck hitting the lip of the bucket. There's another one hitting the bottom of the bucket. That's how specific these codes are, okay? Are those in my book? No, okay? Dream on, all right? It's going to be easy. But again, I will show you what diagnosis codes you will be using, which ones you'll use all the time, which ones you probably won't use that much, and then you got to talk to your vendor as well, okay? So the first thing, and this is what I'm going to, just kind of as a little quiz here, just somewhere, piece of paper, I don't care where, a napkin, whatever, just write down the following. You ready? Put a capital S. So S13.4, and then the X's are small x's, S13.4XX, and then a capital A. I know, I see some of you here, hey, get with the program, okay? Write it down. It will make life easy. Just write it down somewhere, write on your hand, I don't care, okay? So S13.4XXA. As I already told you, that is a cervical sprain. But the actual code is S13.4. The actual code for one of the cervical sprains, S13.4. The XXA is just fluffy stuff, okay? It gives more information. So first of all, the X's, okay? It's S13.4 is a cervical sprain. The XX on that code, those are placeholders. Now, I have a picture up here of some pieces of wood. Let's call it your deck, okay? So your deck has little spaces in between the wood. A sidewalk has little spaces in between the slabs of concrete. That is to allow for expansion. Well, it's the same thing because these codes will probably be around, I think, for the rest of my life, and probably and for sure, till I retire. So as we learn more, and there's different conditions under the family of cervical conditions, now it allows for expansion. Remember, under ICD-9, we had a problem in that there was no room for expansion. Now they've left plenty of room. So S13.4 is the code, XX, and there's a few of them that have 3 X's in Chapter 5, but very few of them. And the ones you will be, I'm only giving you the stuff you're going to deal with on a daily basis. There's a lot of double X's there, okay? And then the A at the end, those 7th characters, which now on your notes you're going to write down Lenny characters, okay? All right? So they're Leonard characters. The A and D, A, D, and S, those tell us basically where the patient is now, where they are in their care. Now, Mario, is this lecture going to change? Or can we use your lecture like the last one for the next 3 years? This here, ICD-10 is in stone. It's not changing. You can buy the 2014 book of ICD-10, or you can buy the 2015 book. It's the same book. They just charge more for the 15 book, okay? They haven't changed. The codes are frozen. But this is the way to, and here I want you to listen to me because this is the truth, okay? Medicare knows how they're going to use A, D, and S. Medicare was going to release their clarification April 16, 2014. Medicare was really mad that Congress delayed everything. They were really mad. And if you look at the law that Congress passed to delay ICD-10 for another year, it specifically said Medicare cannot enact these codes any quicker than October 1, 2015. Do you know why they said that? Because Medicare said we have to enact them by October 1, 2015. We're ready. We're going to do it for Medicare now. Okay? And the government said, no, you're not. And they put it in the law. Now that and other reasons, that's why Sebelius resigned. There are other reasons too, but that was one of them, the tipping point, okay? So A, D, and S, this is basically what they say. And these are the guidelines, but before you commit that to memory, let me tell you how it really is, okay? So the A is the initial encounter. The patient first comes in. You'll see later on in your notes, it says for a new physician. But wait a second. What about if they already are an established patient with me, but they have a new condition? I was treating them for a cervical problem. Now they come in for lumbar. Does that mean I give them an A, a D, or an S? No matter what I tell you, I don't know. Because that is going to be clarified. It will probably be an A. All right? Now, this is what I kind of know. If you look at, like in my book, I have all the codes there that Medicare so far is going to approve. Okay? Now, that is a draft because Medicare hasn't come out and published those codes yet. But when you look at those codes, there are a whole bunch of A's, there's a whole bunch of S's, and there's no D's. So Medicare is going to use those for chiropractic as active care. A. You use an AT modifier now, but that's Medicare. Now, that's what it looks like. Hear me properly. That's what it looks like. But what is it, Mario? I don't know yet. Now, literally, Medicare said they are going to clarify that in about 3 to 4 weeks. Okay? I will let H&S know that when it comes out. I'll post it on Facebook.com. They'll, I'm sure, put it on their website. When all that information comes out, you'll be ready. Now, I will tell you the A, D, and S aspect here is the only thing we don't know. It's the only thing we don't know. All the rest, we know. It's set in stone. So A, look at it here as initial encounter, and then in your note, if you wish, put down in parentheses, active care. Now for me, Medicare, I must have missed that. I didn't check my voicemail recently. They didn't call me up, as far as I know, to ask Mario's interpretation. But the D here, the subsequent encounter, would make sense in our scope of practice here. And it actually, for orthopedic doctors, it is. for the rehab phase. After the patient has received active treatment of the condition and is receiving routine care for the condition during the healing or recovery phase. If you look at the paradigm and basically the way a practice should be set up, you have acute care, then you have rehab, and then you have wellness care. And I'm not talking about in insurance, I'm talking about the way you and I practice. A patient comes in, they don't care about how long they can stand. Doc, I can't stand, I'm leaning against the counter because I did this at the restaurant and I am in so much pain, I'm about a 14 out of 10. Okay? Now the patient now gets into their subacute phase. That's where I would want it to be a D, okay? But the answer is it doesn't look like it in Medicare. Now, Medicare, okay, fine. I hardly do any Medicare, okay? What you have to understand is that there is no HCFA. Those of you that say the HCFA form, okay, part of the word HCFA is hic. Okay, that's what you sound like you have a meth lab and no teeth, okay? Bill Clinton did away with HCFA. He did away with Monica and the blue dress, all in 1994. CMS now runs the insurance world. CMS is also responsible for the security portion of HIPAA. OCR, Office of Civil Rights, is for the privacy portion. So now, all the other insurances literally are waiting at the edge saying, and Medicare is going to give their decree, and they're going to say in Medicare, for chiropractic, this is how we're going to use AD&S. That's coming down all in about the next 30 days. Okay? Once the insurance companies go, really? Okay, now they will do their own policies. Okay? And so this here, that's why I'm taking time, I want you to understand this is changing. Now, S, sequela. Okay, if I put it up there, you'll read it, so fine, let's do this. Okay? So the S, sequela. Did you ever take an x-ray of the cervical spine and you'll say to a patient, oh, you must have had a car accident in the past. And you'll go, no, I don't think so. And you go, well, maybe 15, 20 years ago. Did you ever do that? Okay. Why did you do that? Because you look at their lateral x-ray as an example and you see degenerative disc disease, right? Yes? Yeah, okay. So maybe a loss of cervical lordosis. That is a sequela to the accident. You know what a sequela is. So therefore, and this we do know, because Medicare is using this, is that the sequela is a complication or conditions that arise as a direct result of the condition. In other words, spinal stenosis. Is spinal stenosis acute care or is that a sequela, care for a sequela? It's sequela. And therefore, that's why if you purchase my book, if you look up spinal stenosis, there's an S at the end of that code. Okay? So that I can see, and so now when we look at AD&S, the Lenny codes, okay, now you can think about the A is for acute care, active care in Medicare. The D, we don't know yet, but it may be the recovery phase or rehab, but we don't know, and that may not be it. But S is for sequela. So therefore, degenerative disc disease probably will have an S. All right? Now, don't just say, put an S on the end there. Okay, you have to look the way each one does, but the bottom line is that's probably how it will be used, and that clarification will come in the next month. Questions? All right. After this, starting from now on, everything I tell you will be fact. But this here, that's why I couldn't give them a direct answer, was because it's going to change. Okay, so when we come back, we're going to go through this more.